Thank you, Mayor. Thank you, everybody. I don't know who to speak to, the radical right or the radical left here today, but I'll try to address both of you. First of all, we're going to move right into it because we don't have much time, and there's so much information I'd like to impart upon you, especially the urologists. And this is an exciting time. I think we have three modalities that have come on in the last 5 to 10 years, the robot, the IMRT, and of course brachytherapy. And we're now seeing some results out of these treatments, and it's exciting to see what's happening. Now, just to give you a little background on brachytherapy is not a radiation oncology originated program. It really started out, well, it did start out with this radiation oncologist, Dr. Renken. You probably recognize this, as you probably have several in your radiation oncologists that look like this. But it really started out with Hugh Hampton Young, and who though most of you know is a famous urologist who started radical prostatectomies. But you probably don't know is that as he performed early on the radical prostatectomies, he treated a lot of other patients. And the interesting thing is that he treated them with the technique of placing radium into patients. And this was a technique in which they put radium needles into the prostate gland. So this was really, actually, implantation is not really a new idea. This was actually started by a urologist in the early 1900s. And he did over 500 of these. So it was, so those of you who think, or those of you who wonder about this, it really started out as a urology procedure. And today, of course, it is a cooperative venture between urology and radiation oncology, certainly in the way we do it. Also, many of you are familiar with the Behringer medal in urology. And it's interesting about this because Dr. Behringer was quite a pioneer also in seed implantation, as he started out with the gold therapy and putting seeds in the prostate. So even that idea, he was perpetuated to his work. And he also did a lot of pioneering things in the ideas that we actually do today. The transperineal and suprapubic implantation, the biopsy procedures, the combined implant and external beam radiation, the castration and screening. And so, of course, they gave him the Behringer medal that some of you are familiar with. And this Behringer medal, but you probably don't know, is that on the other side of the Behringer medal is a little tribute to brachytherapy. And down in the corner, you see the seeds down in the corner, that's a tribute to his contribution. So seed implantation is not really a new idea. The application of what's been done in the last 20 years is new, but really the idea of putting radioactive material in the prostate really started out as urology and still is a urology procedure. There's a couple good things that are about prostate cancer is that our death rates for this are decreasing in the past, particularly in the past 10 years, and those are paralleled with also for your results here in British Columbia. They've been very, very similar. Now, here's the interesting thing is that as we look at results, all of us are going to look better. So before any of you get too excited about how good you are and how good your procedure is, remember that over time, over the last 20 years, the prognosis for prostate cancer is overall improved. And it's probably related to our PSA screening and finding these patients, of course, at earlier stage. I know those of you who are my age out there know that when we first got out of practice, 2/3 of our patients were real basically difficult or not incurable, basically because they're palpable disease, and most of them were clinical. T2Cs are higher. But the relative survival rates have improved dramatically. So as we look at results, remember that your results are going to improve just simply because we're seeing better patients. Now, one of the interesting things, I always like to go into different regions and look and see why people die and what happens, and is it any different in their area. So just to identify, and this is stuff you've probably already seen, but in British Columbia in 2000, you had about 3,200. That's a lot of men with diagnosed prostate cancer and about 550 deaths. That's about average for this. You've got a low rate here in British Columbia compared to the rest of the country, which is a tribute to the work you guys are all doing. But I thought it was also interesting to see this study that was done a number of years ago looking at why you died or who got prostate cancer. So I guess you don't want to be a business owner, a manager, a farmer, or a school teacher, I guess a teacher in general. So any of you that are teaching I guess you should probably have a screening after this talk. And so let's move on. Let's talk a little bit about the comparisons between radiation and radical prostatectomy brachytherapy. First of all, as all of you know, is that there's no randomized studies out there. There's no central pathology review. The surgical studies frequently drop the positive lymph nodes patients and positive margin patients in the studies. This makes, obviously, the results look better. And there's different definitions. So, and generally, more favorable patients get radiation. So as we look at some of this data that I'm going to show you, remember put that filter on all of this data. Let's first talk about the low-risk group. Most of your patients are going to be, 80% of the patients now are T1C, are typically low-risk patients. Gleason score is less than 10, or 6 or less, PSA less than 10, and T1 to T2B. You can use Zaleski or you can use a D'Amico, but both of them are very similar. First of all, overall survival, really no difference in overall survival in our studies. We showed that if you compared those to the age-matched group, looking at just actual insurance survival curves, the survival curves are exactly the same. And so that the good news for our patients, and the first thing I always tell patients is that you've got a prognosis that's similar to your neighbors, and so take care of your heart. That's the most important thing you can do, because that's the reason most men die after prostate cancer. Of course, that's the most reason that men die after, anyway. If you look at all the studies looking at the different treatments, that's pretty much true. So I don't think anybody can really claim better prognosis in terms of survival by treatment modality. This is all the studies. Now, what I'm going to show you today is a review of the literature and everything that I can find in literature. And any of those of you that can find other literature, you're welcome to this slide set. And at the bottom of these slides are all the references. And we are building this slide set up so that we can look at these things on a periodic basis, and so that we can compare the results. And so we can talk, rather than select a particular studies out, we can look at where the truth is. And usually the truth sits in the middle. Does age make a difference? There was a study at the Astro. I didn't include that one for time's sake, but this was a study that came out of University of Utah, a resident that worked with us, demonstrating that there really is no real difference between brachytherapy and surgery in terms of tenure, whether you're 60 or above or below 60, but no treatment patients did slightly worse. So it does seem that it is important to treat, but any claim that you tell patients that somehow age makes a difference in terms of treatment, a young man says, well, you should get surgery because you're a young man. That's simply not true. There's at least 3 studies now showing that that's not true, and it shouldn't be told to patients. If we compare the long-term studies this is a study that just came out of Johns Hopkins. We talked to Dr. Hernandez. We got the actual numbers on these. So this is personal communication as well as that paper. If you look at that paper that came out that looked at long-term, it's just one slide that showed it by risk group. But a resident called and found out the actual numbers to these, so that's how these slides were created, comparing to these are matched groups of patients in the risk grouping. But if you look at the low-risk group patients, patients do pretty good, about 86%. Not bad for that particular group out at 15 years. Now, this is a really complicated slide in that this looks at all the patients or all the studies that I could find with modern treatment. These include the patients in the red, with the red triangles of surgery. You notice there's a paucity of your surgical data out there. For those of you who are urologists, if you can find other ones, please send them to me. The blue circles are brachytherapy. There's at least 20 articles now on this subject, and the squares are external beam. I think what you're going to, and then the little ones down at the bottom there are the cryotherapy results. And you can also see the little proton results up here at 79% at 5 years. That's the only study that I could find on protons that looked at risk grouping preoperatively. If you draw a circle around these and look and feel that the truth is somewhere in the middle of all the results here, I think it's a little bit telling is that brachytherapy is doing slightly better than surgery. With brachytherapy now, with the modern techniques that you're doing here, is that somewhere between 90 and 98% of the patients are going to be free of disease long term. With surgery, it looks somewhere between 80 and 90%. Now, is robotic surgery going to make any difference? I don't know. And the reason I don't know is because there's no data. Absolutely no data for looking at pre-operative clinical status and results with robotic surgery. Robotic surgery has been done for over 7 years. Dr. Dahl at Harvard looked at his data. He just presented it here a few weeks ago. I was with him. He does not have any PSA data. I'm concerned about that, and I wonder why. If you look at the external beam results here and add those to them, again, it's clustering somewhere between 80 and 85%. Now, if you look at it overall, as I showed you before, our long-term results of monotherapy for these patients, most of these patients were a little bit more, higher stage, T2As. You don't hardly see any T2As anymore, but 62% of our patients were. At that time, PSA was not used as a screening tool, and it was just coming on. And overall, about 86% reached the nadir plus 2 definition, if you like, and here's the other definitions. But basically, 85 to 86% of the patients were long-term. Are we going to do better? Yes, as I mentioned before, I think we're seeing better patients. This is Greg Merrick's work out at 10 years, 97% of patients being free of disease with brachytherapy. And why is this? This is because I think, first of all, you see a better patient, but also our technique has improved. And when we used that data that you just saw for our long-term was using loose seeds, a very crude stabilization technique. There was no sagittal imaging. There's a bunch of technical issues that we simply resolved over the years, and I think that's what's improving a lot of our results. Is brachytherapy better than IMRT? Certainly the jury's still out on this because we only have a few studies, but this is one study that just came out of Astro. Mike Zaleski. Mike was one of the first people who get an IMRT machine. This is now 7 years out. He presented as Astro this year. 98% of his patients who had brachytherapy were biochemically controlled in the low-risk group versus 88%. There's quite a trend in the United States because of reimbursement rates to do IMRT with urologists owning IMRT centers. And I think this is a little bit concerning because I think the results for brachy are going to be slightly better. Now, what about robotic surgery? Is that going to be better? One of the things that is quite impressive about robotic surgery literature is that it's presented as pathological status after surgery, not clinical status prior to surgery, and then give you the positive margin rates. Almost all the data you'll look at today, and again, I ask you to bring me the data if you can find it, that I'm really looking hard. But it's always given in pathological. So if you select out your patients and find the T2As, you're going to find anywhere from 4 to 15% positive margin rates with the robot T2BCs, 11 to 19%, and of course T3s are 29 to 37%. So if you consider that about 80% of these patients were T1Cs to begin with, you wonder where's the middle here? What's the positive margin rates? Well, my guess is probably it's going to be somewhere around 20%, maybe skewed a little bit towards 15%. So you would expect almost a 15% failure rate right off the beginning, just because of the Parton tables and other predictor models that look at extraprostatic extension. Simply because, why is that? It's simply because the robot prostatectomy, the way it's being done, at least in the United States, and the way Dahl does it and the others, is almost all those patients are being done with a nerve-sparing technique. And consequently, we have a problem with that. And so you predict right off the bat that your results are going to be somewhere around 80 to 85% with low-risk disease. And that's of course, that's what we got with the regular surgery, and I suspect that you're going to probably find that very true with robot, even though technically robotic surgery is better, much better. I just don't believe that you're going to do any better. Why is that? Well, I encourage you, if you haven't done this already, to look at the University of Michigan study, to look at the extraprostatic disease with your patients and look at where the nerve is and where that disease is. And how you do your surgery, because the disease is really just beyond that prostate, right around that nerve. And if you dissect along here, you're going to have a positive margin. And this is posterior lateral area. So it's a concern because the issue really is when we treat cancer is in all oncology, surgical oncology, the surgical principles are is that you treat obviously the organ that's involved, but also you include a margin around it, simply because we appreciate the risk of this microscopic disease outside that surgical margin. So the real question for you as you treat the patient is the disease outside the gland. or is it outside your surgery or implant margin? Well, the question most important for me is it outside my implant margin. The good news with low risk disease is that many of the times the patients do have disease that's confined to the prostate. So that's why it's effective 80% of the time. And when it is outside the gland, it's only a short distance, which is why brachytherapy is so effective. Because when you look at the extraprostatic extension, typically this is only within 3 millimeters of the prostate. Typically, and if you put a margin around that, you typically can get around that. And when we treat with brachytherapy or external beam radiation, we are including a 5 to 10 millimeter margin around it. And of course, we do that around the seminal vessels as well. So every time we treat a patient with brachytherapy or external beam radiation, we are treating the prostate gland and the extraprostatic disease. And that's our basic oncology principle with radiation. With radiation, is you always treat the disease that you know and then the disease that you don't know. And if you look at our dosimetry around the prostate, you'll see that there is margins around it, and these generally are 5 to 10 millimeters with sparing of the urethra so that you don't deliver high doses to the urethra. So just a quick comment about focal therapy, because that seems to be some interest in doing focal therapy, particularly cryotherapy is the one that most people are interested in. The problem with cryotherapy, as I see it, and I think most people recognize there is an issue, first of all, it heats the urethra, and that can spare tissue, and of course that there's a risk of disease somewhere else. So if you're going to do focal therapy, as David Crawford does, they do a rather extensive biopsies beforehand. And David says when they do that, even in patients with the most favorable disease, only about 16% of the patients actually would be a possible candidate for focal therapy. So it's going to be a very small number of patients that are going to be candidates for this approach. And I still think it needs a lot of work to be done before we offer it to patients. When we move into the intermediate risk group, of course, we're going to get into an issue really of extraprostatic disease, which you have to address. This is not an issue that you just flop off and say, well, you've got Gleason score 7, and we're just going to do a radical prostatectomy, and we're going to try to clean you up with postoperative radiation. I think you have to really look at what how effective your treatment is. This looking again at the Johns Hopkins and looking at our studies and looking at the differences between these two results out of 15 years. Now, that's just one study. Again, I don't like to select one study. And if you look overall, you would predict from the Parton tables that somewhere between 60 to 75%, you're going to get about 60 to 75% control rates with a local treatment, simply because of extraprostatic disease. I encourage you to look at the Parton tables or any of those other tables and just pick out all the intermittent patients and just pick out what the risk of extraprostatic disease in those patients. And then just assume for a minute that you're not treating that and predict what the failure rate. I think you're going to find that the predicted failure rate is somewhere between 20 and 35% with just a local therapy. Now there are exceptions to that. Some patients will do well, but I think you have to realize that there is extraprostatic disease in a lot of those patients, and you have to address that up front. If you look at the brachytherapy results now, there are now quite a few studies out long term. This includes both patients who got an implant alone or external beam plus implant. The results are quite good, somewhere between 80 and upwards of the 90% looking at these combined approach. Again, you're welcome to look at these slides. You're welcome to look at the references. You're welcome to give me criticism about this work, but this is kind of how I see it. High-risk patients are even more of a problem. I'm often amazed when I go to the tumor board is that my surgeons will say, well, see, the guy's got high-grade disease, therefore he needs surgery. You need to be more aggressive. It doesn't make any sense to me whatsoever, because those patients are at a higher risk to have extraprostatic disease. And you can't simply just mop them up with radiation. Just go do your surgery and then throw it off to your medical oncologist or radiation oncologist to clean up your work. You really have to address it ahead of time and see how effective your therapy is going to be up front. And also look at the morbidity of these treatments as well. There's no question that local therapy should not be done in my mind, for high-risk disease. In no instance should local therapy done. Why? Let's look at just some of those. I'll get back to some of the proton stuff, but look at the results for the local therapies for this. Anywhere from 20 to 50% you can expect for local external beam radiation. External beam radiation, the problem with it is not enough radiation. with surgery. It's not extensive enough treatment. It's just basic. I mean, there's no. It can be predicted ahead of time for this, and there's so much literature on this now. It's overwhelming to me how much literature is available on this that there's not much question. I think what's interesting is that in the brachytherapy literature, using combined approaches now with combined external beam and seeds and hormonal therapy, that the results are certainly promising enough that you should be considering that as your primary therapy every patient, at least as. And unless you can show me something different than what I found here from all the literature, please tell me why any of these local therapies make sense. They just simply at 20 to 50% control rates are no longer any acceptable. You can start pushing up to 80%. That's just, I think it's remarkable. So why is this? It's because local failure is such a big component of both surgery and external beam is part of failure. There's no question. There's just not enough. There's not enough dose, and there's not enough surgery. You can't get around that disease that extends outside the gland with these high-risk patients. You got to trust both issues. You got to get the disease locally, and you got to get the disease that's outside. So how are you going to do that? Think about that. You look at the surgical data on this, and again, this is just a couple studies. This is pulled from those slides. Area from the Morrison and Kettering of Johns Hopkins. It's just not good. So I don't think you should be. I don't think we should be very proud of doing local therapies in this setting. The interesting thing is that, as I mentioned, is when you combine therapy. This is from Stock and Stone from New York, looking at combined therapy with this high-risk group. They're doing pretty darn good, and not only that, but getting pretty good long-term control of these patients with hormonal therapy, external beam, and seeds. And that's because the seeds give such a high dose that you can control the disease locally, and of course the hormones and external beam deal with the disease that's beyond that. So it's this is astonishing numbers. One of the things I think you should do, we want to spend just a couple minutes. How are we doing for time? I guess we're doing really good. So just to talk a little bit about side effects, and we always have our patients in Seattle do exercises when they have treatment. We got some exercise. Let's talk about some of the other issues that are involved with prostate cancer and some of the risk issues and some of the questions that may come up in your mind, because this often comes up in our tumor boards. Well, what's the risk of secondary cancers? You give radiation, you're going to get a secondary cancer issue. This is looking at some of the SEER data. One of the things about the SEER data is when you look at this information is that it's clear that that age makes the difference. So you really have to be careful about looking at data in which surgery patients are younger, and then look at what the 10-year secondary cancers are, and then look at radiation patients who are older, because there's quite a bit of difference between those patients who are 6 years old in terms of their 10-year risk of getting secondary bladder cancer and a guy that's 60 to 79 years old. So unless you stratify for that, it's going to look like your radiation patients get more cancers. And in fact, when we looked at our data was quite similar to implant alone was quite similar to what you would expect with the normal population with bladder tumors. With implant alone, we had a slightly greater percentage of patients had external beam plus seeds. So there may be a little bit of an issue. Now, I've never had to have a patient have a cystectomy. These have always been able to be treated with a TURB. We got into. I got some extra slides in here. Sorry, we got beyond. Let's go a little bit about some of the score, and actually some of this is done by Myra and Jim and everyone here, which has really looked at the results of resolution of their score. Is that it does take, after a seed implantation, it does take a while for patients to normalize their IPSS scores. So typically most patients within 12 months will resolve it, but they actually, even after that, they'll continue to improve their score, but it may take a number of years for them to get out to return back to their normal function. as they showed, definitely you can have periods of time in which this worsens. This typically is often somewhere between a year and 2 years after their treatment. They'll have a period of time in which their urinary symptoms inexplicably come back. They'll get some dysuria, they'll get some frequency. You'll treat them, and then it'll go away. And we're nearly not quite sure why that occurs, but it also can be accompanied by an elevated PSA, a PSA bounce. There's some speculation that this may be a result of cell death. Also, people have speculated that may be related to microvascular necrosis that's causing some inflammatory effect here. But again, I think Myra did a nice job of showing how these will typically resolve. Do hormone therapies affect the IPS score? This is Greg Merrick's work. Looking at those, it really did not really make a difference in normalization, whether the patients were on hormones or not. If you look at alpha blockers, patients who are on prophylactic alpha blockers do slightly better. So those that are on therapeutic blockers or that you wait until they become symptomatic don't do quite as well as those patients who you start on it before. And so for the most part, we start patients on alpha blockers usually several days before the procedure. They continue on it until they get some resolution. Incontinence. Incontinence is probably the issue that's probably most important for patients. I think it's the one that affects patients' quality of life more than the sexual function after it. Surgical results. This was results that were given after or in a group in the Harvard, Boston area for nerve-sparing and non-nerve-sparing. The incontinence rates, and this included both stress and non-stress stress incontinence, anywhere from about 19 to 26%, with brachytherapy and external radiation 2 to 4%, pretty low. Now, is the robotic surgery going to make a difference on that? Probably yes. Most of the data that I'm seeing, robots, is somewhere between 10 to 12%, of which about 7 to 8% of that is stress incontinence. The other 3% is related to regular incontinence. So usually what we quote to patients is that they've got about a 10%, after robotic surgery, have about a 10% chance of some degree of incontinence. After SEEDS in our center, it's less than 1% chance that they're going to be incontinent, and that means having to wear a pad for any reason. If you certainly don't want to do a TURP after procedure, after brachytherapy, that it significantly increases the risk the patient's going to have incontinence, though. So if the patient's had brachytherapy, do a TUIP, do anything else, but try not to go in and do at least a big TURP. If a patient has obstructive problems where he really is obstructed, and this is usually we wait until beyond 9 to 12 months before we do anything, we will then try to do a very minor procedure. We don't like to go in and traumatize that urethra. Once you damage that urethra, you have repair, and it's really the vasculature that around the urethra there is damaged. You're now relying on the vasculature of the prostate now, not on the urethra vasculature for support, and it's not as good. It has a tendency to break down a little bit more, and I think the patients have more problems. So we're really, really gentle with that urethra. So when you go in and you look at those patients after brachytherapy, don't just jam that thing in there and cause trauma from your procedure, because that's going to have a hard time healing. Part of the sexual dysfunction I wanted to chat with you briefly about is to talk about what we mean by that. We often talk about potency. I think that's a bad term. It's a basket term that doesn't mean anything to anybody. You should talk about either erectile dysfunction, ejaculation dysfunction, climax dysfunction, or fertility, because that's what potency is, composes of potency. Just a couple things. Erectile dysfunction we'll talk about a little bit more, but it's dependent on their preoperative function. If they're good, they're going to do better after brachytherapy. Ejaculation fluid, almost all the patients notice some decrease in that. And I tell patients not to expect to have fluid. If they do or they don't, it has no bearing on their cancer control. but almost all patients think that the fluid comes from the prostate, as you know. So you have to explain it to them that it does not. Climaxability, almost all patients can climax, despite their amount of fluid and despite their erection ability. So that's something important for them to understand. I do tell them that their climax experience is going to be probably different because they don't have the fluid, and so they have a different sensation. Fertility, the seeds are not a contraceptive. It's not likely they're going to be, able to conceive, but we did have one 78-year-old guy impregnate his 39-year-old girlfriend. He was not very happy with us because we had not explained that to him. His wife was even less happy with him, and it was a bad day in the office. So you might want to do that. Generally, your sexual dysfunction, again, this is a very difficult area because patients come to it and so much, there's so many factors involved here. The questionnaires, you can almost find anything you want to on the literature in terms of supporting your treatment. This was Jim Talcott's. Jim's not a radiation oncologist or a urologist, so this was just a survey again of that group in Boston. It did show that there was a little bit worse with surgery than with brachytherapy or external beam radiation. I will tell you, if you look at all of our literature in brachytherapy, and I apologize for busy slides that are difficult to read from a distance, but the potency preservation generally means erectile maintenance and penetration. It's anywhere from maintain about 50 to 70%, 80-some percent. But again, this is largely, none of these studies, or very few of the studies, actually separate these patients out, stratify these patients out in the pre-operative or pre-treatment ability. And I think that's a critical factor in determining what the effect of the therapy is. And as you do your studies, I hope that you will stratify your results based on that. Because I can't make heads or tails out of or what really to tell patients. It does seem that if the patients have partial loss, which in our studies, if they had normal abilities to start with, about 10% of those patients lost the ability to penetrate at 2 years. If you look at them at 5 years, it's going to at least double that. If they had partial, which is about 50% of them had partial loss of their ability, they weren't firm as durable, they do respond to Viagra or Cialis. About 80% of those patients will do better. So, and also, so when you look at your studies, you have to look at that aspect about it as well. It says, are they taking one of these agents to improve their ability, and what's the effect of that? So you need kind of to stratify those patients who don't take medication, what's there, and then if they do, how effective it is. So the good news is that many patients do improve. One of the things technically that we've done in brachytherapy is we've recognized that the penile bulb region beyond the prostate gland is likely an area, at least partially responsible for impotency. And of course, that's the junction box. I call it the junction box of the nerve coming down to the erectile tissue and the corpus cavernosa. So if you think that's true and you keep your dose away from there, and it does seem to be evident by both the external beam and seed implantation data, is that you may be able to improve your potency rates by simply keeping your dose from that. We also place patients on a rehabilitation program afterwards, which includes those exercises I jokingly referred to, but it involves stimulating an erection frequently, at least 3 times a week, and the use of Cialis at least 2 or 3 times a week, and it's to try to maintain their ability. We think that there may be some benefit to that, and also gives some guys something to do. And as I mentioned before, it does make a difference. This is Greg's work. It does make a difference whether there's partial or full potency to begin with. Does the external beam make things worse? It's possible it does. There's kind of controversy about this. If your technique is good, it may be that your external beam does not worsen the potency issues. So this is going to have to be sorted out. We are now using a technique which we are very, very careful now using Calypso technology to make sure that we keep that border really tight and not treat that area beyond the gland with that external beam. Typically in the past, a lot of that area was treated rather generously. Does it make a difference age? As you can imagine, it does. The older you are, the worse you're going to do. So if as you're stratified into these issues, you get age in there as well, you can skew your data one way or the other just by picking younger patients or having younger patients. Strictures, certainly strictures do occur. Generally, it's related to the urethral dose, so we pay attention to that more now than we did in the past. But you're going to see about a 1% to 1 to 5% chance of strictures. It's primarily so as we do our planning, we try to keep our dose minimal to that area. How are we doing? We doing okay for time? Yeah. Okay, we got about 5 minutes. Okay. If you look overall for obstructive and irritative effects, clearly external beam or seed implantation is going to be worse than surgery. Because a lot of times when you're doing the surgery, you're removing some of those problems of obstruction, and as a result, then those patients are going to improve because you remove the offending problem. With brachytherapy or external beam, sometimes patients will have a chronic irritative effect. Fortunately, it's not too bad. It usually managed pretty easily with medications. It's rare that patients are debilitated by it. How about retention requiring a catheter? It's used generally with modern technique, with approaches that we do. It's generally going to be somewhere between 3 and 7%. So it's not going to be very often that you'll see patients that require a temporary catheter. This is always a temporary catheter. I haven't had any patient with permanent catheters. The only patients that have required a straight catheterization, and it's usually because of stricture distant down the line, but nobody's had a permanent catheter. So identifying the patients with that will require catheters, if you use your IPS score, those patients over 20, I think if you want to use a rough rule of thumb, you may be able to just use that score as kind of a rough rule of thumb about the probability of them requiring a temporary catheter. If you look at dysuria, some patients do get pain. Almost all patients have some discomfort urinating, at least initially, right after the procedure for at least the first day. That goes away fairly quickly. There are a small percentage of patients who have discomfort urinating for a period of time. This invariably goes away with all the patients. So if you see it at a year out, the guy's having discomfort, you can reassure them it's going to improve. I don't really know the reason for this all the time, and I put them on all kinds of different medications, antibiotics, anti-inflammatories, alpha blockers, everything, and hold their hand, and I'm not sure what is the reason why they get better. I wonder sometimes that there may be a very, much like interstitial cystitis, maybe effect on the mucosa there that just takes time to heal. And so some of those agents, for that may be effective, but as you know, many of them take many, many months for them to be effective. But it generally heals with time, which suggests that this may be just a mucosal issue and a local irritation. Bowel problems are pretty uncommon with any of these treatments. Bowel problems are primarily manifested as maybe an extra bowel movement a day, occasionally some bleeding. It's very, very rare to have any rectal ulcers. It generally depends on rectal dose, and for the most part, we've identified the problem with that with some techniques, and you're not going to see that very often because the technique you use in keeping the rectal dosages down. And it's generally very self-limited when bleeding occurs. Usually you see it between 1 and 2 years. It goes away. You don't really have to do very much about it. You just hold their hands. Just a couple things about it, looking at overall some of these incidence rates. Again, that they're all over the board a little bit, but generally related to dose. Mostly these are pretty low risk. If you look at, people say, well, is it going to increase with external beam radiation? There's generally the impression that adding external beam radiation could increase it. It certainly was a concern of ours, so we're very careful now of keeping that external beam field only within a half centimeter of that prostate gland to minimize the amount of rectal tissue that's treated. But there's really not a lot of difference between that and implant alone. What's the fistula rate? We've done over 5,000. We've just had a couple. I've had 2 cases in my career, 20 years of doing it. Had no other choice for treatment, and he had a very small gland, so we thought we'd get away with it. We did not. And the other guy was an attorney, of course, who I told not to have a cautery of his rectal bleeding. He did anyway, and he then subsequently had a colostomy because it didn't heal. So if you do this long enough, you probably will develop a problem, and few patients, hopefully it'll be very, very low risk of that. If you're Kent Wallner, Kent's a very aggressive guy who uses high energy seeds a lot of times and a little bit more cavalier in terms of dosages. He had a higher rate, but nobody else gets that kind of rate. Same thing with external beam radiation. It didn't seem to be much different, but we're certainly cared. For those of you who think, well, I'll start pointing at that, go, oh, you see, there, they have rectal ulcers. Surgery has its own problems too, as you know. So don't get too on your high horse about it. There is some injuries both from surgery. Okay, we talked about the rectal cancers, and I think we're running out of time here. But just talking about the incidence of rectal cancers, there doesn't seem to be much association. There's a couple studies that seem to suggest that there was some increased risk over surgery with external beam radiation studies. When we looked at our studies that had external beam rectal cancers, in a 10-year period, there's a 0.6% chance of that. The take home in our minds is that beforehand, if you look at some of the Baxter study and the Gutman studies, is that you really want to really want to do a colonoscopy beforehand, because many of these patients, first of all, these cancers and these colorectal cancers are not even close to these implants, and also some of them were preoperative or perioperative cancers that occurred before the treatment, and were not related, or occurred very shortly after the treatment, which could not be correlated to the treatment itself. I think we already talked about the secondary bladder cancers. You look at something about the radical prostatectomy. If those, again, talking about complication rates, you're going to have the same kind of complication. You're going to have some complication rates with laparoscopic prostatectomy. This is Mark Kawachi's. Mark's done a lot, as you know. So it's not. There's nothing here that's perfect in terms of overall treatment in terms of being complication free. So I present our problems with radiation, but also I think you have to be fair that there's a chance that if you treat with surgery too, you've got problems as well that you can encounter. So this is the truth for any treatment we have. So the point being is that the bottom line is no matter what you do, sometimes things go wrong, regardless with the patients that you have. So what I thought I'd do is I'd stop there, and then we can talk about some of the issues that we brought up. Thank you.